He's been telling me for a decade he's practically a doctor. So we're going to put that to the test. Seriously, though? He is not a doctor. He's an idiot. Also, medicine is constantly changing, so I'm probably wrong too. The point is, this is not medical advice.
Good morning.
Good morning.
What have we got?
I have a 74-year-old African-American male. He's 119 kilos. Came in with lightheadedness and confusion. He has an allergy to latex, past medical history of hypertension. He had an acute MI 4 months ago and a small PFO. His heart rate is 127. His rhythm is AFib. Blood pressure is of 168 over 98. Respiratory rate is 16. The patient is afebrile and his stats are at 94%. Neuro-wise, he's got slurred speech and some facial drooping. From a cardiac standpoint, pulses are 2+, brisk cap refill, no murmur, irregular heart tones. Respirations are clear throughout, no respiratory distress noted. Abdomen is normal, has good bowel sounds, no concerns or complaints noted from a GU standpoint. Musculoskeletal, he does have some right-sided arm and leg weakness. He is on a daily multivitamin, lisinopril and metoprolol at home. He's got a PIV. We haven't gotten any labs or anything yet, so that's all I've got.
We're using different gloves, right?
Yes.
Because we're allergic to latex.
Oh, yes, we're using the nitrile gloves. Thank you.
Good.
Pointing that out.
That was the thing I noticed.
Always on, keeping me on my toes.
Yeah, listen, it's important. Let's see here. So droopiness and things, that is likely a stroke.
Oh, I mean, could be, yep.
Let's check for that.
Okay, how would you like me to check for that?
Let's see if his brain is
there?
Good. No, I'm sure it's still there. I'm a doctor.
I didn't notice any holes in the head. So.
Good. That's good. Check for those anyway. Let's see if there is. What do we do for? Oh, wait, hang on. I can do this. Of course I can.
I would hope so.
I'm a doctor.
You get paid the big bucks.
Let's do what checks the brain? A CT scan?
Okay.
Does that check? That checks the brain?
Yep.
Yes. Do a CT scan and see if we have a stroke.
Okay, will do. Anything else you want me to do in the meantime?
Yes. I would like you to monitor him closely.
Okay.
The AFib, things like it could be a problem. So what does the heart? An EKG does the heart.
EKG. Okay.
So let's check the heart because there was something you said there that sounded bad.
Okay.
Ta-da!
Is that it?
Yes.
Sounds good.
You don't have those results yet?
Oh, no, because I'm still standing here.
Oh, okay.
Come back in a moment with those results.
All right.
Your CT scan did show an embolic thrombosis.
That's what I suspected.
Yep. So what are we going to do about it?
For an embolic thrombosis, that means that the heart is doing stuff it's not supposed to. So we should make it do things that it's supposed to. So that feels like something blood. Let's try blood thinners.
Okay. Any particular blood thinner, or you want me to start some Coumadin, or
yeah, that one sounds good.
Or
whichever. You know what? Let's go with what were my options?
Coumadin, heparin, Lovenox.
I like
aspirin.
heparin.
Heparin?
Yes,
okay.
I actually met with their sales reps earlier. So let's go with them.
Okay.
And do a normal dosage.
Okay, yeah, I'll talk to pharmacy.
Yeah, whatever the normal one is, that's fine.
Okay, so we're going to start him on a heparin drip. Anything else you want to do?
We didn't get the CT scan back?
The CT scan showed an embolic thrombosis.
Oh, that was, what would the EKG show?
That's in the brain. Oh, the EKG showed atrial fibrillation.
Oh, okay. That's good. Let the heparin take care of that too.
Yep, okay, heparin for everything. Got it.
And let's go with some antibiotics, just because that feels like a thing.
Okay.
Yes, I like amoxicillin.
Amoxicillin, okay.
Sure.
Great. I'll get those started.
Fantastic. Everyone else, carry on.
you killed the patient.
Was it a stroke?
It was a stroke. I was shocked, not shocked.
Droopy face. Listen, droopy face was a strong.
Droopy face, I knew was going to get it. You were going to know what it was. Treatment is where we struggle.
Yeah, I had no idea what do you do
struggle.
That's true. So you seem to be. Well, you were also having a hard time not laughing at me. So I think we both have opportunities for growth.
That's true. It's really hard. All right. So actually, you were on point with your CT scan.
Okay.
It absolutely has to be done emergently. And so you would want a stat CT scan right off the top.
Okay.
Because you do need to know where the stroke is located. The other thing we need to
know...
Wait,
time out. Is it the CT? Oh, CT is the head. I was right about that.
Well, you can do a CT of anything.
Okay.
It's how the images look. Now, you could get an MRI in this patient. However, that's not indicated because it takes a lot more time. And not all hospitals have good MRI machines available.
That's
readily
weird.
Available. So they wanted something that was standard across the board because time is brain when it comes to stroke.
Time is brain?
Time is brain. So how quickly you can get things done is how much brain you're going to save for that patient.
Oh, okay.
Because you have to treat them quickly.
You said time is brain, and I thought perhaps you'd had a stroke because that wasn't...
Time is brain.
Time is brain. Okay.
All right. So
I'm low on time.
CT scans can happen a lot faster. You go down, it's a few minutes, you've got images. So CT scan was on point. EKG can happen eventually.
There was hard stuff.
Waste of time. There was heart stuff. So actually this patient was at risk. So lightheadedness and confusion, it's important to know how long that's been going on and when the symptoms of slurred speech and facial drooping. So a lot of times slurred speech, especially in older patients, is confused for confusion. So they're confused. So then it's not treated right away.
Gotcha.
Which you have to know, it's really important to know when the stroke symptoms started showing.
Okay.
Because that's going to determine a lot of your treatments.
Got it.
Okay. Your fibrinolytic therapy, so your TPA or antithrombosis medications that you can give, different from blood thinners.
I couldn't think of anything else. I'm like, I don't know. The stroke, blood needs to flow. Thin the blood. Thin the blood.
Thin the blood.
Give them some booze.
So we would prefer TPA, not heparin. Those can only be used in the first 4.5 hours post-stroke. That's actually a longer time frame. It used to be 3 hours. Now it's 4.5 hours. And you have to rule out a bleed first. So that's why you have to do the CT scan first. Because if you give this, so sometimes a patient can have an embolic thrombosis, but then also develop hemorrhagic strokes after, or downstream from where that thrombosis is. If that thrombosis is stretching the vessels at all, or if there was an aneurysm.
So then the blood is bleeding into the brain.
So if you give them something that's going to cause bleeding, it's going to make that worse, and you could.
And now you got more blood in the brain, and that seems like bad.
If you put them on a heparin drip, you're not really that takes a long time to get that thrombosis gone or smaller, and you're increasing the risk of bleeding. So
gotcha.
Heparin is not your choice of drug there. The other option, it's best if done in the first 6 hours post-stroke, is a mechanical thrombectomy, which is where it's the coolest thing. It's the coolest thing.
A mechanical thrombectomy. I can't believe I forgot about mechanical thrombectomy.
Thrombectomy. So they put a catheter, just like you would do a heart cath. They put a catheter all the way up into the brain to where that thrombosis is. They use a little catheter to pull this clot out, and they take the catheter out. It can take 10 minutes for them to do. And patients can recover very quickly.
That is so cool.
Isn't that amazing?
That is really cool. All right.
So ideally, you want to do that in the first 6 hours post-stroke. There are some patients that can have that done up to 24 hours, but there's certain criteria that they have to meet.
Gotcha. So still very dead.
Your patient is very dead because we did an EKG, started a heparin drip, got some antibiotics on board.
Listen, I just wasn't in a rush.
Definitely going to kill your stroke patient.
Time is brain.
Time is brain.
Time is brain. That's the thing here. All right. I guess we'll see if I kill the next one.
Yep. Hint, you do.